Hello, Dr. Dave Mc Carty. Uh,
Hello, Sharon. It's good to see you again.
yeah, thank you so much for being here. We're looking forward to you sharing some of your pearls of wisdom, of which actually not some, but your many pearls of wisdom. And we're going to talk about why do I or my children need to see a sleep specialist? A little bit of there are many reasons because sleep science is complex, right? But you've
Yeah,
developed
this
something.
is exactly right. This is exactly right.
Yeah.
The complexity of it is the problem, and sleep and wake are complex phenomena, and it takes but very little introspection to understand that there's a million ways you can screw up how the sleep experience feels and how the wake experience feels, and they're all interrelated to one another. So unpacking this complexity is a difficult thing, and understanding the different types of diagnoses that you can end up with is part of the process. It's understanding, well, what could go wrong? What have we seen out there? And understanding that these diseases appear or these deviations from normal, I guess, appear in certain patterns. And that's what we're going to talk about first, right? Is the different classifications of sleep disorders, right?
Yeah, absolutely. And I think one of the hardest things for parents is understanding when they actually need parents, but sorry, not just parents, but health professionals. I
Right.
would say virtually every
Or
healthcare
teachers,
professional,
or yeah, or
everybody.
other caregivers in the chain. Yeah, all of us need to understand this stuff because we're all caring for each other, right?
We are, but usually people don't really know, number one, how to access medical expertise or why, and sometimes, or perhaps often, they don't even know where to go,
Hmm.
because there are accessibility issues. But what I thought might be really helpful is to go through five of the most common sleep disorders because there's more than 80 and we don't have time for that today, right? But
Sure, but we can talk about the different classes. Yeah, and that can help.
yeah. Why don't we talk about insomnia? What in children and what would alert parents or healthcare professionals about the presence of insomnia?
Well, I'd like to start with the word itself. So, in my clinical view, the word insomnia, although it's classified as a type of sleep disorder, it's a complex phenomena as well. And so, insomnia really begs an intense investigation for causes that are provocative factors towards that symptom that the patient may perceive as inability to sleep when given the opportunity. So, with that being said, insomnia kind of happens without other problems provoking it. And there are a number of reasons why that can happen. And it doesn't necessarily mean that the brain is broken or anything like that, but it does require a provider to uh, dig a little deeper. When is it time to worry is really the litmus test is when it becomes a functional problem. So if the inability to sleep at night is leading to daytime consequences, is leading to intense parental involvement, that's creating functional difficulties for the parents, that's a time to start digging a little deeper, understanding that there is no one solution for the phenomenon known as insomnia, but there is a way of digging into that complexity that most people can understand.
And so, see, insomnia could be difficulty falling asleep, waking in the middle of the night, not being able to go back to sleep,
Yeah.
waking way too early,
Hmm.
before the roosters, so to speak.
Right.
Um, and in the classification, I think what I've heard is it has to happen at least three times a week for 3 months to be diagnosed. Is that right? In the
Yeah,
ballpark?
these are the set points. When does it become abnormal? How many times a week? And you have to understand that these things are designed to try to create some degree of accordance when we're trying to research these things. So did they meet the criteria as defined by this? And then, the person can be included for studies. But on a clinical boots on the ground level, it becomes a problem when it's a problem, you know?
It's such a
And so
great
that,
distinction. Yeah,
mhm.
yeah.
So, there should be a clinical distinction between am I studying this? Can you be included in my study because you met the benchmark? Or am I helping an individual with their problem? And in the latter sense, you have to sort of meet them at boots on the ground level and understand what they're going through. So
Yeah, and I was interested that you said, that it's happening for no explicable reason. Did I understand that correctly? So it wasn't a
well,
physical
insomnia
thing.
is a complex phenomenon, and it felt to understand. There's something called the Spielman 4P model. So there's the predisposing factors towards insomnia. This might be some sort of medical disorder that elevates the resting tone of the sympathetic nervous system. This may be PTSD physiology. This may be sleep disordered breathing. It could be one of these things that raises the overall spark of the sympathetic nervous system, predisposing factors. Then a precipitating factor. Something happens. Your parents get divorced. You lose your job. Something throws things into a turmoil. Then there's perpetuating factors. Once the insomnia has become a problem, now you are starting to have maladaptive behaviors. Oh, if I'm not sleeping, then I'm going to do this. I'm crying in mom and dad's room. I'm turning on the lights, doing all these things that can disrupt the cycle and perpetuate. And then finally, the fourth P is Pavlovian factors. The whole conditioned aspect of insomnia is part of this psychology. And that is, if you have repetitive problems sleeping in your bed, you will learn that you are a person who has problems sleeping in the bed. And when you get into the bed, you're like, okay, here we go. And it's the conditioned
Yeah,
response. It's very similar to the physiology of a cancer patient undergoing chemotherapy will start to feel nauseated sometimes the moment they arrive in the parking lot,
yeah,
because it's anticipatory. You're like, this whole
yeah,
scenario is making me sick. So the whole scenario of going to bed can contribute to the sensation of insomnia. So intervening on insomnia means recognizing that there's many levels to this. And this is kind of where we get into the whole cognitive behavioral therapy for insomnia thing. And in my view, once again, if you teach some of these things to people, oh, you should just be in bed for a limited amount of time, then you'll sleep better. That's called sleep restriction therapy. It's part of CBTI. If you just tell people to do that without them understanding why, they're going to look at you like you got two heads and they're going to leave. And then they're going to talk bad about you behind your back, you know? So part of the language of my project is trying to help people understand these basic physiologies of how these things work so that everybody can be on the same page with treatment.
yeah. And it's not an overnight fix.
It is not. It is definitely not an overnight fix. It
It
requires
really.
careful deliberation, and the careful deliberation part isn't unilateral. This is a complex system. And so the only way to understand that system is for the provider to have a probe and response technique. There is no, you have this, do this, go away anymore. We've moved
Yeah.
beyond that.
So that relationship between the family and the physician or the psychologist or whoever is involved in supporting that family is key, really
Yep.
important.
Key that it's kind of a co-discovery process, to use the verbiage of my friend Dr. Paul Henney. It's a co-discovery process, which means both parties are empowered with the knowledge of the complexity of what we're working through, and having the proper tools to responsibly unpack that complexity is really what it's all about.
Yeah, fantastic. Thank you. Now, what about restless leg syndrome? Wriggledy, jiggledy kids, helicopter
Yeah.
kids in the bed,
So this
waking
is
up
more
on the.
common than you might think. Restless legs. I'm looking at my image in the video now. I realize I should have had my hairdresser. Restless leg syndrome kind of has a bimodal population. It happens in childhood and adolescence, and then it happens again in adulthood. And uh, the reason for this is that it has a very strong relationship to iron and iron delivery to the brain. And it happens that rapid adolescent growth is an iron consumptive process. And so kids often become symptomatic with what's called restless leg syndrome, which is an uncomfortable sensation in the lower extremities that just makes you feel like you have to move them. And if you
Mm,
move them, it makes it go away for as long as you're moving them. But the really challenging part of it is that it's usually worse right when you're trying to go to bed. And so the kids will be moving their legs around. Oftentimes, this is related to a phenomenon that the kids aren't even aware of, called periodic limb movements of sleep. So those are non-volitional, almost metronomic, regular leg movements that you can see on a sleep study. Um, Restless leg syndrome is complicated though, because the whole title of it, the diagnosis, restless leg syndrome, falls short of what this problem truly is. So some of the eggheads that are studying this in academia are using a modern eponym for this problem called Willis-Ekbom disease. Willis-Ekbom disease. And what that means is that it's bigger than just the restless legs. The symptom of my legs are restless and I have to move them is a part of this. And it's a very annoying part of this for some people. And it's a perceptible contributor to sleep disruption for some people. But then there's also the notion that there is evidence of dysautonomia with this. So there's an irritable bowel component to this. There has been an association with night eating urges. So not eating when you don't know what you're doing, but just having these insatiable urges to consume calories at night is related to this. There is the whole phenomenon of periodic limb movements of sleep, those non-volitional periodic movements of the legs. So just calling it restless leg syndrome is it's cheating what the whole vision of this problem really is. And I'll tell you, this is part of the reason why this complexity needs to be discussed. Let's talk about the person who has those periodic limb movements of sleep, right? Every time the leg movement jerks, there is a subtle increase in sympathetic nervous system activity, and there is an arousal from sleep. And this can create an instability to the breathing pattern that in older adults can become central hypopneas. And this is a person that might end up getting a diagnosis of sleep apnea because the sleep study was abnormal, when the root cause of that was this movement disorder at night. You see why the complexity needs to
Yeah,
be addressed.
yeah.
So,
Sorry,
no,
I
no,
couldn't help thinking of the word forensics. Actually, it,
yeah.
the
There are
forensic.
many bidirectional relationships here, and understanding how those bidirectional relationships fit together is a pretty tangled web. So most providers kind of shrink their focus because it's less scary. Quite frankly, this complexity is a very difficult juggernaut to get your head wrapped around. And if those complexities can be unearthed in a simpler fashion using story-like relationships, then suddenly things get a little easier. And I don't know if you cued your listeners into or your watchers into the Empowered Sleep Apnea Project, but that's what that's about. It's about trying to put this complexity in a way that is not terrifying and actually helps everyone understand what the playing field looks like.
And it's important to have this forensic approach because that's how you figure out how to treat it effectively.
Yeah.
Yeah,
Yeah, you drill down to
yeah,
what's actually causing this,
yeah,
guys. What's causing these complaints that this person came to me with?
yeah,
Can we get to the bottom of those complaints? We're not just trying to get to the bottom of a single label,
yeah. The
Oh, you have sleep apnea? Yes.
perpet,
We
predisposing and perpetuating factors.
yes,
Yeah,
that's right. That's right.
yeah, yeah.
So as I often do, my stream of consciousness went to sleep apnea and complexity and bidirectional relationships. Let's go back to the list. We were talking about classes
Oh,
of sleep
okay.
disorders.
Sure. One of the other ones on the list is narcolepsy, and that
Oh
is
yes,
no laughing matter, right?
it is not a
Because if you
laughing matter
laugh,
at
you
all.
might fall asleep, actually.
Well done, well played, well played. Yes, narcolepsy. So narcolepsy can be thought of. There are two types of narcolepsy, but to the person who's experiencing it, typically it presents with an inexplicable um, episodes of sleep that are inappropriate for the amount of time slept at night. There are two types of narcolepsy. The best understood is type 1 narcolepsy. It sounds a little bit like type 1 diabetes because it shares a similar pathophysiology, it's thought. It's thought that this is an autoimmune destruction of certain cells within the hypothalamus. And these special neurons secrete a neurochemical called hypocretin. And hypocretin's job is basically to help stabilize sleep and wake. It's kind of a master puppeteer. And without hypocretin around, a little bit of extra sleep pressure from being awake has a tendency to make people have dozing episodes at really inappropriate times. Without hypocretin around, there can also be dysregulation of some of the mechanisms of REM sleep. So this is what you were talking about with laughing. So REM sleep, rapid eye movement sleep, dreaming sleep, is a physiology that's typically associated with vivid, intense hallucinatory activity because we're dreaming, right? It
Mhm.
seems real. And it's associated with an absence of motor tone. So the only muscles that are working during REM are literally the eyes and the diaphragm to keep us breathing, and some little muscle in the middle ear too. But the bottom line is that during REM you're supposed to be paralyzed. So the weird thing about type 1 narcolepsy is you can trigger that atonia with emotion. So instead of being appropriately triggered by going into REM sleep, you have a strong emotion. Usually it's a gust of laughter, and then suddenly, boom, you're a jelly person and you can't
Or
stand that.
crying or any other big
Yeah, it could be
emotion.
negative
Yes.
emotions too, or anger, sudden anger. So it's
Mm,
usually sudden emotion, excitement, or being surprised, like if somebody jumps out
mm,
from behind a door, you know,
mm.
and it's not losing consciousness, it's not fainting. You just go to rubber and your legs drop out from under you.
Yeah.
So
So
it's a
it's like a
very
collapse.
strange, yeah, you could collapse for sure. Yeah. And this
Yeah.
is actually something that can affect quality of life.
Mm,
People have stopped playing contact sports, for example,
mm.
because, danger. They've sort of toned down there and created emotional masks for themselves so as not to sort of feel anything because it's an uncomfortable thing to have happen. So
And what
it's a,
age?
it's a,
Oh, sorry.
no, no, go ahead.
I was just
I was
thinking, what aged children are you more likely to see that developing? Because it happens in kids, right?
It happens, and the presentation in little kids can be different. For the cataplexy that we've just described, it can be something as subtle as a facial sag, where they're kind of just like they'll go a little limp, and so it can be mistaken for other things for obvious reasons. Boy, is that kid limited in some way?
Or petit mal,
Everybody
epileptic
Yeah, everybody starts
seizure.
labeling. So yeah, petit mal seizures, for example.
Mm,
So, but we start to see this in school age kids, grade school kids. Again, it's because it's often following a burst of immune activity. So whether it's a native infection or it was associated with one of the vaccines, polyvalent vaccines,
mm,
about 10 years ago. I believe it. Oh, I'm going to missay it. So I just remember it was a vaccine. I believe it was for flu. But correct that if it's wrong later. I'll stand corrected. But the bottom line is that this is something that happens with strong immunologic stimulation. So if you get challenged by a native infection, it can happen after that too.
yeah. Okay. What about what? Oh, sorry. Before we go on to parasomnias, I'm thinking, how common is narcolepsy in children?
It's more common than people realize, and so it's listed on the rare diagnosis list. And I'm not going to give you a prevalence rate because it all depends on how you find, and so you'll get differences in that. But
Mm,
it's common enough that it's likely to be seen by every primary care physician at least once in their
right.
career. And so in adults, the prevalence rate is listed as similar to adults with multiple sclerosis. And so people understand that that's something that's around. And so I think just understanding that you should expect to see it, it's not one of these rarities that you're never going to see. It often just goes undiagnosed because people don't know what they're looking at. And so the
Mm,
complaints can go unnoticed. People can compensate a variety of ways. There's a lot of self-blame that goes along with it because they've been labeled along the way.
mm,
So there's a whole psychology that the people with narcolepsy sort of need champions. They need people to shout out and say, "Hey, this is out there." So
mm.
and that's what I'll say about prevalence is that we need to know it's out there.
Because undiagnosed, it could be misdiagnosed as something else.
Yeah,
Yeah.
and usually the terms are pejorative. You're lazy, you know. Why are you
Yeah.
sleeping on the
You're not
job?
trying.
You're not, yeah, yeah.
Yeah.
You're depressed.
Mm,
There's all kinds of labels you can put on this that kind of are, I guess you'd call them patient shaming.
mm,
And as providers, we need to know that that's out there and just
mm,
understand that, these folks need our help.
mm,
So if we start to hear some of these symptoms that are a little odd, hey, I laughed and I fell down the stairs, or, I just can't stay awake sometimes.
mm,
We deploy our tools. We have a great tool for, for a daytime sleepiness tendency, the Epworth Sleepiness Scale, so you can deploy a tool like that. And if it's looking like it's a little bit off the mark, then that's when one can get into a complexity untangling tool, like maybe we can talk about later, but the 5-finger approach to sleep-wake complaints. Oh, we recognize that there's a problem now. How do we
Mm.
unpack that? Hey, there's a 5-finger approach that we can use so we can not overlook anything.
We don't want to miss anything.
We don't. And we
No.
don't want to put a label on them and have them not get better and then lose faith in us
Yeah.
because, we got part of it, but we only got 20% of it, you know.
Yeah.
This often happens with a disorder that now most everybody has heard of, sleep apnea. You come in with a set of complaints, you get the label, you get on the appropriate treatment, and after that, it's kind of hazy what's going to happen. If you're not feeling any better, often the advice is, well, keep using your machine because I can see you've only used it, blah, 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 blah. And that's where the thinking kind of stops.
Mm.
So what we need to understand is this is a patient-centered enterprise. It starts with the narrative. So how do we break that narrative down? Well, the 5-finger approach is a good beginning.
Mm.
And if any of the listeners are wondering what I'm talking about, this is readily available to the public. Just Google 5-finger approach sleep, and you'll get to my original paper published in 2010 that just shows this as a teaching tool. It's called Beyond Occam's Razor, and so everybody can download it. The PDF is free to everybody.
It's a great paper. I think everybody should read it. It's
Oh,
required
I use
reading,
it to
should
this
we
day.
say?
Yeah, it's the best Swiss Army knife for solving problems.
Yes, yeah, it's really good. We are going to talk about the 5-finger approach or the 5 reasons to treat, but let's talk a little bit about parasomnias
For
first.
sure.
And I've left the sleep disorder breathing till last, and it's not last but least. It's,
It's
because a
it's
lot of the
last but
people.
most commonly recognized. So we should put it last, sort of the way we think about it, I believe.
Yeah, yeah. And I think though most of the listeners are interested in breathing and
Mhm.
breathing with sleep. So I wanted to leave that for us to talk about last. But also, as you said, to show that it's not just about breathing, there's lots of other things
Mhm.
that can go wrong. But let's talk about parasomnias and
Okay.
children.
Yeah, so parasomnias can be loosely defined as strange or unusual behaviors that have to do with sleep. And they can be broken down into several different categories, but the way they're characterized is they're disorders of arousal, which means that there are general consciousness states that we understand as that guy's asleep, and it's characterized as, limited movement, quiescence, posture that's kind of, gravity dependent. You know what I mean? So this is sleep. And then there's wake, where you're walking around, you have volitional control of your actions. Somewhere in between there is where the parasomnias lie. So it's something people really get excited to talk about. These include things like sleepwalking, a strange phenomenon called cataphrenia, which is this sleep-related groaning. There can be sleep-related uh, 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 I'm blanking on the words. I'm having a senior moment. Um,
Sleep
uh,
talking,
Sleep talking. Thank
sleep
you. So sleep
terrors. No, that's
sleep
something.
talking and sleep terrors. Confusional arousals is another one where they appear to be awake, but they are drunk and sort of out of it. But they're interacting with their environment in a strange way. So, there are many different classifications, but the bottom line is it's unwanted or strange behaviors that are happening during sleep, and they require a workup because part of the differential for this could be nocturnal seizures, which can create
Yeah,
strange movements and behaviors during sleep.
yeah.
So it's not something that we can totally blow off, but for people that are now freaking out, sleepwalking is really common, and
Mm.
it's very common in childhood, where there's a lot of growth involved, and that creates a lot of sleep pressure. So any little awakenings are likely to lead to a incomplete awakening, and this can lead to getting up and wandering around and sleepwalking and things like that, or night terrors. Most kids will usually grow out of it by the time they're in their teens. And usually the response to it is not medication, but reassurance and redirection, making sure that the sleeping environment is safe. That
Mhm.
we don't want to have sharp corners or, weapons or something that they could access in the room, something like that. But
Mhm.
mostly it's geared around safety. Um, when safety is a concern, when it's a really repetitive problem and there's a lot of sleepwalking involved, and it's clear that this is going to get people into trouble, then we can start talking about using medications. And often it's a very low dose of a benzodiazepine derivative. So usually clonazepam is what's used. And the good news, the bad news is that's a drug that people worry about. It's a drug of potential abuse, and it's a drug that can potentially lead to habituation if misused. But the good news is that for these types of cases, usually it's a low dose, it's once a night. The problem goes away, and we see no evidence of dose escalation. So, over time, so as a sort of a risk benefit ratio, it seems like the right thing to do in that case. Um, I
Yeah,
guess
one
I'd
of
add
the things I'm, oh,
one more
sorry.
thing, and that is any parasomnia also requires another dive into, well, why is this happening? Again, so this is where the
Mm,
five-finger approach comes in, so you don't forget. Just because you have sleepwalking, well, oftentimes the sleepwalking is provoked by something like sleep disordered breathing. That's the thing that's pushing them towards arousals. Or perhaps it's the restless leg syndrome. That's the thing that's pushing them towards arousals.
mm.
So all of these categories have cross linkage to each other,
Yeah,
right?
and one of the other interesting things that I've read, correct me if I'm wrong, about parasomnias is that it's going to happen in the deeper stages of sleep, stage 3, 4.
Yeah, that's true for non-REM parasomnias. REM parasomnias are really rare in kids. They can happen, but it's rare. Most of the time, if you see REM behavior disorder in a kid, it's because they actually have narcolepsy. So there
Mm.
is a thread between those two. But uh, non-REM parasomnias are what's more common in children, for sure.
Yeah, and in terms of sleep architecture, the deeper stages of sleep dominate that first half of the night.
Oh,
So
for sure,
possibly parasomnia is more likely to happen in that first half of the night.
for sure, for
Yeah,
sure.
yeah.
That is
It's
true.
so
And
interesting. So
yeah,
many things that can happen. And there was a day when they thought that when we went to sleep, nothing was happening in the brain. And yet it's
right. It
quite
just
the
turned off.
opposite.
Like stadium lights coming off. Everything just shuts down. Yeah, we now know that's not true. There's a lot happening there.
Yeah. Yeah. Thank you so much for that. Let's move on to sleep disorder breathing.
Yes.
Audible breathing, chronic airflow limitation. When it comes to kids, this is super important. Just
And
breathing a little bit harder than the body needs is going to
mhm.
lead to fragmentation or disruption to sleep. Tell us what you know.
I want to talk about this because the term everybody knows is sleep apnea. And so the question often becomes, does my child have sleep apnea? Yes or no? So what I want to emphasize to this audience is the breathing at night is a spectrum, okay? Whether it's perfectly healthy or heavily diseased, there is a spectrum along that. And the cut point about whether it's sleep apnea or not is often made by, whether insurance is going to cover for this problem. And so there's a score that's involved. So there's a lot of subtlety in concluding whether there's a problem with breathing at night. So I'm going to sort of say that flat out. The phenotype of sleep apnea that many adult providers carry in their mind, which is a heavy patient who snores heavily and has daytime hypersomnia, sleepy in the daytime. That phenotype is only one head on this multi-headed monster. So for children, the things parents should be observant for are patterns of breathing at night. So I like what you mentioned about the posture of the jaw. Open mouth breathing is not normal. It's not what we're supposed to be doing. And it robs the midface of the opportunity to develop properly. Because the midface develops, and there's a great narrative to support this, but this part of the face develops in this dimension and in front to back dimension because of where the tongue is. And if the mouth is always open, it never gets that opportunity. So if folks know that there is this functional relationship between growth and development, and the simple observation of what is the posture of your child's face when they're breathing at night?
Mhm.
Is the mouth open or closed? Is it making rattly noises, Darth Vader noises? These things are not functionally optimal. What is optimal? Quiet, mouth closed,
Mhm.
nasal breathing. And you shouldn't really be able to hear it. Now, how does sleep disordered breathing present? Like, what if you couldn't observe the child at night and you were the child's teacher? What would you see? Well, you might see mouth breathing. You might see kind of big circles under the eyes. You might see a narrower face developing that way. You might see a kid who has a lot of attention deficit and hyperactivity symptoms, more impulsive than his peers. You might see a kid who's falling behind. So there are many ways to label that phenotype in our world. And our purpose as folks who understand airway health and breathing health and how it's pertinent to development is to recognize those signs early and understand that there is a narrative towards orthodontic expansion that is now available to everyone to understand. So the old understanding is, well, if the teeth are really crooked, we'll take some out and we'll pull them back so they'll be nice and straight. We're now dealing with the consequences of that philosophy, which is that it creates a more crowded oral vault, and that creates functional problems with breathing. And for a child, it can create the requirement for mouth breathing throughout crucial developmental years. And this is something that has adult consequences.
And I really like that you brought up the issue around mouth breathing because it's serially dismissed as a not a problem, probably because it's so common. And if you go to the shopping centre or you go out anywhere in public,
You'll
we
see
will
it.
see more than half of the population mouth breathing.
Yeah.
And so for many people, it's considered normal. And yet it does have an impact on breathing during sleep that can fragment it. Do you want to talk a little more about that?
For sure, yeah. So the open mouth breathing posture functionally places the jaw. This hinge joint is here for the jaw, right? So when you open the mouth, the jaw hinges back, which functionally disconnects the tongue from the roof of the mouth, and it tends to fall backwards. And what you end up with is an airway that's more likely to collapse during an attempt to pull air through it, because those structures should be kind of pulled up tight like a rubber band. And when they're released, when you try and pull air through, it's like trying to suck a thick chocolate milkshake through a floppy paper straw. It just sucks together. And then what you get is and that is an uncomfortable experience. We are evolutionarily bred to dislike the experience of, choking, even though it's on a milder scale. Having a functional limitation to breathing is something we're bred to dislike on a physiologic basis. So that's going to create a little burst of adrenaline, and it's going to create an arousal from sleep. So
Mm,
this can, in the long term, robs a person of attaining and maintaining deeper levels of sleep. So
mm,
sleep cannot do its purpose, which is to kind of clean the brain out from all the waste matter of the day, if it's fragmented like that. And it prevents certain stages of sleep. Often people have this problem much worse in REM. And REM is what we need for procedural memories, man. If you're only getting 15% of the REM you should be getting, how are you ever going to learn to play the piano?
mhm.
You know? So it creates functional difficulties that are subtle and hard to track, but they're definitely going to lower the person's quality, perceived quality of life.
Yeah, and that might be ignored in the health system, I think, is probably one of the key things. And you've also talked about muscle functions at
Mhm.
rest and the importance of the tongue raised to the roof of the mouth, also head and neck aligned, lips together. And there's a lot of reasons why that's important, but one of them, when the tongue is suction to the roof of the mouth, that is literally the most open position of the airway. But in small children, particularly, that tongue to the roof of the mouth is, as you said earlier, it's what helps the system grow.
Yeah,
So,
every time we swallow in that position, it puts a little bit of stimulation to, hey, maybe we should expand this. That's what does it. Without
Yeah.
that pulsatile stimulation, it
Yeah.
just doesn't happen. And then we get what the old guys used to call adenoid facies,
Mm.
because concomitant with mouth breathing, you usually get dysfunction of the lymphatic tissues too. We're robbing ourselves of the natural ability of the nasal airspace to cleanse the air, and so we're challenging all of those microbes and whatnot onto the lymphatic tissues, the palatine tonsils, the lingual tonsils, and the adenoids.
Mm.
And so mouth breathing is going to contribute to it. Anyway, all of this being said, that elongated, skinnier face with the sunken eyes and the retracted jaw, this is what they used to call adenoid facies for that reason. And it's all related to mouth breathing.
Yeah, and it's a little bit of a vicious cycle because if this craniofacial system is
Yeah.
developing narrow and smaller than is ideal, then there becomes resistance points to breathing.
Hmm.
And then that leads to negative pressures in the airway that can even pull juices up from the stomach,
You
which
got it.
then inflame. We get laryngopharyngeal reflux that can inflame at eustachian tubes, the
You get chronic
sinuses, the
sinusitis.
nasopharyngeal
Absolutely.
spaces, etc. So it's a bit of a vicious cycle. And I think one of the really important things to help healthcare professionals and parents to understand the importance of intervening early with something
Yeah.
that looks so simple like mouth breathing.
Yeah, and learn to self-advocate, because this is an increasingly fragmented healthcare system, and the terminology I use in my Empowered Sleep Apnea project is it's increasingly siloed, which means that providers have a hard time learning new information, and if it's not in accordance with kind of what they're doing, and so many parents and patients in this journey are often met with providers that they've not been able to learn the complexity and how to unpack it just yet. So they're told you don't have a problem, or that's normal, or so. What I'm hoping that we can all do together is help patients develop the language to self-advocate. And, if necessary, they can point to now published works. Like you can say, well, I've been listening to this podcast, Empowered Sleep Apnea, and I understand that this is more complex than that. And open the conversation, because that's really what this is going to take culturally to bridge these divides. It can't come from mandates from academia, because they're doing their thing, and they're drilled in to the way they're doing things now. And it's hard for people to communicate in that regard.
In the perfect world, we would love that to happen, right?
Hmm.